when it comes to disease, one thing that we always talk about, and I may have discussed this with you previously before this study, is there's always this conversation around inflammation, um, and uh, oxidative stress. And I'm wondering if there are measurements for oxidative stress in any way, shape, or form, or kind of like a presence, because even when it comes to things like acid reflux, whether it's silent reflux, things that are degrading the mucous membranes, and then there's studies that talk about how cytokines can kind of like there's this crossing of the membrane and then kind of triggering an autoimmune response in another part of the body that's beginning in one part. You have things like MS, right, where women are more likely to have it, and even what is it? NAD plus receptor encephalitis, where again, women are more likely to get it. And we're thinking, does it start in one area and then kind of move along? And I'm wondering if any of those kind of factors with these themes that keep coming up when it comes to disease states might be going into, things like SIBL, where people might be more likely to get them. Even with oxidative stress, you have people who are neurodivergent are more likely to respond, how it impacts like depression and how stress impacts oxidative stress and things like that. And that makes me think of socioeconomic factors. That makes me think of pollution. That makes me think of epigenetics and things like that. So are any of those things kind of going into this multitude of, this immense amount of data that's going into SIBL? I wonder
I
what
I love that you brought up oxidative stress because in my previous life as a PhD student and then as a postdoc, I worked on the mitochondria basically,
the
and
powerhouse of the
the
cell, I hear.
powerhouse of the cell line and how it integrates into cancer
Mm-hmm,
in
mm-hmm.
specific. So oxidative stress is something that's near and dear to my heart. So what we're going to be doing is, or not that we're going to be doing, we are doing it. We're collecting blood samples on these patients enrolled in the lung cancer screening program here. These blood samples will be used to analyze for metabolites, to analyze for cytokines, to analyze for immune cell populations. And then we plan to integrate that data along with SIBL scores. I think together, that's back to my point about integrating biology with, SIBL scores. I think hopefully from that work, we'll be able to develop more personalized lung cancer screening and potentially have better factors to kind of predict who's going to go on to develop lung cancer than what we have right now. This has all, I mean, not to go off, but, we think about screening. We screen a lot of people who don't need to be screened, right? They meet the criteria, but we know that across that cohort I talked about, the NLST cohort, only about 1% of patients in that who qualified for lung cancer screening, that's based on age and based on smoking history, actually went on to develop lung cancer, right? We're catching obviously a lot of lung cancer early, and that's great, but we're screening a lot of folks that probably don't need to be screened. And we also know our own data, about 3% of our patients in the same population develop lung cancer. So there's disparity there, right? So while, we're picking up patients, we're not picking up everybody. And then even when we are, there are disparities within those populations of who's going to develop lung cancer. And so, you can see we need better tools to kind of personalize lung cancer screening. It's not a one shop fit all sort of thing, which is kind of how it's set up right now.